Well, greetings, everyone, and welcome to the EKG case for the week of March 12th, 2013. This week's case was sent to us by Dr. Monica Luciak. Monica is a second-year emergency medicine resident at the Parkland program. That's University of Texas Southwestern. It's a great program. And the residents at that program have sent me more excellent EKGs than just about any other program I can possibly imagine, except perhaps our own residents. Although I have to bribe our own residents by giving them big, giant chocolate chip cookies for every good EKG they give me. And the folks at Parkland have never asked me for any cookies before, so I thank you all, and thanks to Monica for sending this EKG. But if I run into you guys at ASEP, I will get you cookies, all right? So keep them coming. Anyway, Monica had a case of a 40-year-old woman who presented to the emergency department with some shortness of breath and some orthopnea. And on brief history, they discovered that she had a history of metastatic cancer. Now, cancer plus shortness of breath, the first, second, third thing that you're probably going to be thinking of is pulmonary embolism. And we've talked some about pulmonary embolism EKG findings before. We can talk about it again. But there's one other really, really, really important thing that you've got to think about, especially in this day and age. You've always got to think about the possibility of one other thing, and that we'll talk about in just a second. When you've got patients that have a history of cancer and they present with shortness of breath. Well, this was the 12-lead EKG that Monica and her colleagues got on this particular patient. And there's probably an abnormality, or actually a triad, that's jumping out at you already. And unfortunately, it's not always this obvious. But anyway, what you're looking at here, this is a sinus tachycardia, for one thing. So the patient's tachycardic. Well, that doesn't narrow it down. This is a sick patient. So tachycardia is very present in many sick patients. There's also really small QRS complexes. There's low voltage in the limb leads. There's low voltage in the pericardial leads also, and we'll talk more about low voltage. And probably, if you've been looking at this EKG for 5-10 seconds or so, you're probably also noticing what we refer to as electrical alternans. The QRS complex is getting bigger and smaller. Overall complexes are relatively small, but they're changing size. Now that we refer to as electrical alternans. The QRS complex has changed in size. There's other types of alternans that you can get also. Sometimes you can get what's called total, it's not a California term, but total electrical alternans, not totally alternans, but total alternans, where the QRS goes up, and then the QRS goes down, and then the QRS goes up, and the QRS goes down. That is referred to as total electrical alternans. You may also get P waves that are following in the direction of the QRS complex as well. And you can even get T waves that are alternating in direction. And there's different names. Sometimes people refer to that finding as total electrical alternans. But anyway, the key point here is that when you've got the QRS complexes, especially, that are changing direction on a beat-to-beat basis, or changing size on a beat-to-beat basis, in at least one of the leads, oftentimes you'll see it in a couple of other leads, and in this particular EKG, you can kind of see it in a few leads more prominently than others. That is relatively specific for large pericardial effusions, not necessarily tamponade. Tamponade means that there's also physiologic problems like hypotension or right heart collapse. But when you see this alternans, it is highly specific, though not pathognomonic, but highly specific for a large pericardial effusion, and especially in a patient with a history of cancer who's presenting with shortness of breath and orthopnea. Well, you've pretty much got your diagnosis right there. So I just want to talk briefly about pericardial effusions. We talked about this before, actually, in November 2011. If you scroll all the way back on the website, that www.ekg.umem.org, scroll all the way back to November 2011, there's a 16-minute video that talks all about pericardial effusions, and I'm just briefly going to recap that. You recall the classic triad, and I oftentimes joke, it's kind of a joke, not totally a joke though, but the term classic in medicine means it's not always there. Classic means it shows up on the boards, but not always in real life. Classic to me also generally means 15%. in medicine. And this triad, although it is classic, it is not present in the majority of cases. Maybe not as low as 15%, but more likely the electrical alternans, you'll only see it in about 30% of cases, and the full triad you probably get in about maybe 15 to 20% of cases. So don't rely on electrical alternans. But again, on the board exam, electrical alternans, low voltage, tachycardia, that's your classic triad. But I do want to remind everybody that in real life, alternans is not always there. It's only present in about 30% of cases, and the full triad in real life is only present probably in about 20% of cases. What about low voltage? Let's talk briefly about low voltage. How do you define low voltage? Sometimes people just look at an EKG and get this gestalt of low voltage, but it does have a more specific definition. This is the definition that I learned from Dr. Edward Chung, who is an EKG guru at Jefferson Hospital in Philadelphia. It's a simple definition. It is fairly sensitive. You might read some others, but this is the simple one that I remember. What you do is you take the QRS complex amplitudes in leads 1, 2, and 3, add them up. If it adds up to less than 15 millimeters, call it low voltage. So if we go back to this 12-lead EKG, the QRS complex amplitude here is about, 4 millimeters, and that's about 4 millimeters, and that's about 4 millimeters. 1 plus 2 plus 3 equals less than 15. That means it's low voltage. The other way of defining low voltage is take the QRS complex amplitudes in V1, V2, and V3, and if they add up to less than 30, then that is defined as low voltage also. We'll go back to the 12-lead once again. So the QRS complex amplitude, even if we take the bigger one here, that's about 8 or 9 millimeters, and then that's about 12 millimeters, so up to 20, and then maybe take that one, and V1 plus V2 plus V3 is less than 30 millimeters, and so that is low voltage also. Okay, so and remember that the word "or" is here, so somebody can meet low voltage based on that or on that. This particular case meets low voltage based on both of these criteria. You'll read some other definitions that are a little bit more specific, but this is the definition that I like. And if somebody meets this criteria, then I call it low voltage, and I start thinking about a handful of things in the differential for low voltage. Here's my differential for low QRS voltage. And I split this into two categories. You can have low voltage if the heart is weak. I think of the heart as a battery having low power. If that battery or heart has low power, you're going to have low voltage. What kind of things give you low power? Well, severe hypothyroidism or myxedema can give you low voltage. End-stage cardiomyopathies, not early, but end-stage cardiomyopathies can give you low voltage. And then infiltrative diseases like sarcoid and amyloid, those can also produce low voltage because they make the battery weak. And then the other thing is that if you have conduction blockage, then that's going to also produce low voltage. You think about the heart producing this current, and then here's the person's body. Well, here's the person's body. I'm having some trouble. Here we go. Here's a person's body, and there's the EKG leads out there, and this current has to travel a certain distance to make it out there to be picked up by the leads. If there's something blocking that current, for example, let's say there's a pericardial effusion, there's a lot of fluid, you're going to get a decrease in conduction of that power out to the leads. Let's say that you've got a pleural effusion, there's fluid in the lungs, and that's blocking the current. That's going to produce low voltage. Let's say that there's a lot of fat, the person's obese. Obesity will produce low voltage. And also, let's say the person's got a barrel chest from COPD, and this is all air. Well, that's going to produce low voltage as well. So that's my differential for low voltage. When you see low voltage, think about a weak battery and think about something blocking the current from the heart out to those leads. All right, so simple take-home points. First of all, don't rely on alternans. It's always in the textbooks, it's always on the boards, but in real life, again, alternans is present in less than 30%. What's probably more reliable and what you're going to see more often, a combination of low voltage plus tachycardia. whenever you see low voltage plus tachycardia, forget the alternates. Low voltage plus tachycardia, get your ultrasound and rule out pericardial effusion, especially if that low voltage is new. If you get an old EKG and they didn't have low voltage before, but now they do, you've got to worry that the patient has a pericardial effusion. That's a deadly disease that you can't afford to miss. All right. So again, here's a nice example of a patient with low voltage. Add those up, it's less than 15. Add those up, it's less than 30. All right. Low voltage plus tachycardia. This person had prostate cancer with pericardial effusion because of a metastasis to the pericardium, and the patient was bleeding into the pericardium, and we nearly misdiagnosed this patient as having a PE, right? Prostate cancer plus shortness of breath, you think that's a PE, but think about pericardial effusion. We got a 12-lead EKG, saw tachycardia and low voltage, and so rather than thinking PE, because of this EKG, we got the ultrasound, we saw a big pericardial effusion, we made the proper diagnosis. Notice there is no alternans on this 12-lead EKG, just tachycardia plus low voltage. So simple take-home point. Tachycardia plus low voltage equals pericardial effusion until proven otherwise. Just get your ultrasound and take a look. And back to the case that Monica sent. Again, thanks so much for sending a great case to talk about. The patient ended up having a drain of a large pericardial effusion and hopefully is doing well now. Again, thanks to the folks at Parkland for sending these EKGs, and hope that case is helpful. Remember, if a person's got a history of cancer and they have shortness of breath, don't just think about PE. Think about pericardial effusions also. Look for that low voltage and tachycardia, and if you see it, get the ultrasound. I hope that was helpful, and I will talk to you next week. Bye for now.